and with that, we will move on to the next session for today. And in order to begin that, may I please request our respected chairpersons and panelists, Dr. Debashish Banerjee, Dr. Shourav Mukherjee, Dr. Debashish Mukhopadhyay, and Dr. Shoubhik Kanjilal to begin with the next session. And the first speaker for today's second session is Dr. Rituparna Barua. We will directly start with Dr. Barua's presentation. So, Dr. Barua, over to you.
Thank you so much. At the onset, I just want to my gratitude to the West Bengal CSI Society and Dr. Shourav Banerjee sir for this prestigious platform to give it to me to speak on this particular very important topic. Is a clinical context. So I want to share my slides. So the slides are visible. I hope so. So this is the clinical context. A 66 years old lady, diabetic patient, hypertensive, has presented with rapid onset progressive shortness of breath to the emergency department with a blood pressure of systolic 160 and diastolic 100, with a heart rate of 120 per minute and these atrial fibrillations. And the SpO2 has gone down to 82% room air, and the pro-BNP level was higher, is 2400. Quick echocardiographic assessment was done, and ejection fraction was found to be 60%. Pulmonary systolic pressure went up to 50 millimeter mercury, and at that moment the creatinine was 1.7, and sodium, there was hyponatremia of 124 milliequivalent, and potassium in slightly higher range, mild hyperkalemia. So this is the clinical context, and my job is to how to manage this patient, particularly the acute care of the patient. Particular in this context and managing the renal function worsening. Before going to the case particularly, we want to discuss about what is the information or the knowledge right now we are having to treat this kind of patients, so that the management may be much easier and more effective. And as you know, it's acute heart failure. So this is the presenting history, and the most important, the quick assessment of the probable etiological factors in this patient, because we see that the acute coronary syndrome, ischemic heart disease, and this cardiomyopathy, myocarditis, and the arrhythmia-related tachycardia-induced cardiomyopathy, and the patient usually present with the severe anemia. So we are actually dealing with patient heart failure with reserved ejection fraction. So the apart from the acute coronary syndrome, the other etiological factors may be more important in that particular patient. And then in our context, the severe anemia leading to heart failure, and the other hyperdynamic circulations, and the hypertensive heart failure as the patient blood pressure is higher. But it could be the other way around also, because of the heart failure, the patient may develop higher sympathetic drive that can lead to increase in the blood pressure also. So these are some of the quick assessment of this patient, like electrocardiogram and the oximetry analysis, the echocardiometry that we already discussed, the X-ray, lung ultrasounds, particularly very helpful in this group of patients. And as the already is given in the context of the patient, the N-terminal pro-BNP level. So these are some of the quick assessment of this patient. So the main target of this particular clinical context is to stabilize the patient. So another important clue that we are having is atrial fibrillation. Because the patient has atrial fibrillation, we do not know whether this patient, some of the history is very, very important, because whether this atrial fibrillation is a recent onset or acute onset atrial fibrillation, very fast ventricular, that can worsen the clinical situation of the patient. And these are some of the important parameters or important assessment that we must do in the serum troponin and the creatinine that we already discussed. And also important that electrolyte. Electrolyte is very, very important, because the hyponatremia in that particular that clinical context could be dilutional, or the patient might be having existing hyponatremia, or the patient might be having some drugs, antihypertensive drug, hydrochlorothiazide, hydrochlorothiazide, or already on some group diuretics. Because of that also, that the sodium wasting, and the patient may present with hyponatremia. But in the particular context, we have seen that the potassium is also higher and the creatinine goes up. So, so we hope that this is actually a clinical situation that leading the cardiorenal syndrome and which retention of potassium, which dilutional hyponatremia. And the iron status of the patient is also important. Accordingly, the thyroid, D-dimer, the lactate level in ABG is very, very important. So in that clinical context of the patient, the arterial blood gas analysis is a very important marker, and all the mostly most important parameters that is those are very very prudent to know in that particular situation of the acute heart failure uh, can be found in the ABG analysis. And most important management in this particular patient is that the congestion, the fluid overload situation, and to overcome. And also second important is that is there any organ hyperperfusion. So if the patient is having a congestions, and then basically the injectable loop diuretics are the cornerstone of the management, and you must first relieve the congestion of the patient. In this patient, because the blood pressure is higher, so the vasodilator therapy to reduce the blood pressure, to stabilize the blood pressure and the acute heart failure situation is very, very important. And in that particular case, we have seen that the SpO2 has gone down to 80%. So the most important thing, we have to keep the situation of the patient more than 93%. So immediately putting the patient in NIV, and if the patient is not responding to NIV and the persistent low SpO2 is observed, so we can electively ventilate the patient, because elective ventilation is much more beneficial compared to the non-elective ventilation. So increasing the diuretic dose and the combined diuretics, because in this particular situation, the diuretic resistance is a very common phenomenon. So to break the diuretic resistance, we can start the injectable infusion of the diuretics like the furosemide, and then we can aid on the acetazolamide, because that helps to break the diuretic resistance. And also important is that the patient is not responding to this therapy. So renal replacement therapy in the form of alpha filtration is very, very, very beneficial. So most important is the oxygen and the ventilatory support. So accordingly, we discussed that the sign of hyperperfusion is there. So we can start on noradrenaline or some kind of separation, vasoconstrictor substances, like most commonly we use the noradrenaline, and along with the loop diuretics together, so that we can manage the congestion part and also maintain the mean blood pressure of the particular patient, so that there should not be any significant organ hyperperfusion. So optimizing the fluid status is very important, and sometimes in the emergency room, we do the echocardiography to check for the intravenous, the IVC, the dimension of the IVC and the collapsibility of the patient, that we can assess, but it may not be always correct in that particular clinical situation to know the fluid status of the patient. So if the IVC is dilated and not collapsible, so in that patient, the central venous pressure is significantly higher, so we must do something very hurriedly. And non-invasive ventilation in that particular situation is very, very beneficial. And sometimes those patients, the hyperperfusion is not relieved by the conventional intravenous medication or NIV or the ultrafiltration or the ventilatory support. So the ventricular assist device and other mechanical circuitry support is very, very important, that being discussed in the previous discussion. So, and accordingly, the etiological factor that is responsible for the worsening of that particular patients is to be very meticulously found out, and according to the treatment which should be provided in this group of patients. So these are some of the important factors that could be responsible, like we already discussed about. The etiological factors is very, very important. So quick assessment of the etiological factor like acute coronary syndrome, the hypertensive emergency, the tachycardia induced cardiomyopathy, or the atrial fibrillation can lead to this kind of heart failure, preserved ejection fraction of pulmonary embolism. So these are some of the important factors that always keep in mind while treating these patients. So the goals is in that particular case that is given to me is first is to determine the etiology, the alleviate symptoms, and the improved congestion and the organ perfusion is utmost important. That the restore oxygenation by giving the nasal oxygen or face mask oxygen, or the NIV use, or something that is not responding to an IV. So we can provide the mechanical ventilatory support. And important is that there should be close monitoring of the vital signs and the severity of the assessment of the severity of the symptoms and the position of the putting the patient in the ICU or intensive care is very, very important. So accordingly, we can assess the treatment or effectiveness of the different pharmacological therapy provided to the patient, like the vasodilators. Most commonly use the MGZ and sometimes the nitroprusides, the parameters fulfill the criteria, and the immunosuppressors used. So these are very, very important factors determining the improved survival in this group of patients. So these are some important flowchart that if you are using oral intravenous diuretics, loop diuretics particularly, so how much effective that particular loop diuretics you can judge from the urinary spot stadium or urine output level. So this is some of the guidelines that I have read in the ESC. So these are very important parameters while assessing the echocardiography. Is important in heart failure with reserved ejection fraction because this patient ejection fraction is 60%. So LA volume index and the E prime ratio and the pulmonary arterial systolic pressure. So these are some of the very important parameters to know the response of the therapy. So this is the recommendation in ESC that if the saturation is less than 90%, so oxygen must be usually intubation is recommended for progressive respiratory failure persisting in spite of the oxygen administration or non-invasive ventilation. The NIV ventilation should be considered in patient with respiratory distress if the respiratory rate more than 25 per minute or oxygen saturation is less than 90%. And it should be started as soon as possible in order to decrease the respiratory distress as quickly as possible and reduce the rate of mechanical and electrical intubations. Intravenous loop diuretics are recommended for all patients with acute heart failure admitted with signs and symptoms of fluid overload to improve symptoms. A combination of loop diuretics and a Pfizer type of diuretics should be considered in patients with resistant edema who do not respond to an increase in loop diuretic doses. Vasodilators that we've already discussed about in patients with heart failure with a systemic blood pressure of more than 110, the vasodilators may be considered the initial therapy to improve symptoms. Inotropic agents, if the systolic blood pressure is less than 90 and there is evidence of hyperperfusion, so we must not delay and then immediately the inotropic agents should be recommended so that to maintain the perfusion of the vital organs. So among the suppressors we commonly use in our epinephrine may be considered in patient with cardiogenic shock. And the thromboembolism prophylaxis is sometimes required, particularly in my patient because the patient presented with atrial fibrillation. And the mechanical circulatory support and other shock management being already discussed in the previous sections. And this is the definition of the worsening renal function because the case also shown that there is a worsening of the renal function. The patient is developing some form of cardiorenal syndrome. So according to the definitions, 0.3 mg per deciliter increase in creatinine. And also can be defined as more than 20% decrease in GFR. Different studies evaluating the patient factors that contribute to the development of worsening renal failure. The baseline serum creatinine greater than 2.5 is an independent risk factors for decompensation heart failure. Reduction in systolic blood pressure have also been associated with worsening renal failure, suggesting that the decreased cardiac output and reduced renal perfusion could be a key contributor to the development of worsening renal failure. Paradoxically, this report showing that the worsening renal failure accompanied with a decrease in systolic blood pressure is not associated with mortality. And these hemodynamic variables like the elevated central venous pressure have been reported to be very strongly associated with worsening renal failure. To particular, my patient that presented with this worsening renal failure, and it appears to be a stronger predictor of mortality than elevated pulmonary artery capillary pressure. And also important factor that must needs attention is the hemoconcentration. So if the patient develop hemoconcentration and worsening renal failure, these are frequently experienced renal function recovery because the hemoconcentration, actually there is a diuresis and then there is hemoconcentrations that could be a factor that can determine the recovery in the discharge of the patient. And the late hemoconcentration at the peak of hemoconcentration 4 days was reported to be associated with later survival, because if the patient considered to be in early concentrations and in that particular phase of treatment, so there is a possibility that we can decrease the dose of the diuretics and the patient may remain hypervolemic, and that is why the delayed concentrations could be a better predictor of outcome compared to the early concentrations. So particularly the loop diuretics, once they develop some form of resistance or the addition of metolazone or thiazide, and ultrafiltration can improve the diuretic resistance in acute heart failure patients. So this is the trial, effort trial, that recommended the use of the study, the use of the cetirizine intravenous 5 mg twice daily, and on the top of the furosemide, so that's showing the beneficial effect. And we already discussed about the NCLUS trial, the SGLT2. Once the patient is clinically stable, so we can add SGLT2 inhibitors to in that heart failure with preserved ejection fraction. Atrial fibrillation, that is another factor may be responsible for worsening of the heart failure and also worsening for the renal function. So the immediate attention to be paid to this group of patients to stabilize the. And in that case, if the patient hemodynamic is not stable, and we can actually externally cardiovert this patient, and so that we can immediately revert the patient, but there is some form of complication may arise, like embolism, systemic embolism, but that has to be taken care of a different mechanism, particularly the anticoagulations. So the rhythm stabilization is very, very important. This is another molecule, tolvaptan, because this patient already has hyponatremia, and this is numerous trial actually showing us the beneficial effect of the tolvaptan in this group of patients where the patient is having hyponatremia that could be related to the hemodilutions or hypervolemia, and provided the patient creatinine clearance is more than 30. And there is some benefit shown in grading of dyspnea, diuresis, and the reduction of the body weight, and improvement of the hyponatremia. And also there is improvement of the pulmonary capillary reverse pressure, but there is lack of very strong data on, regarding this tolvaptan. And this patient has already developed hyperkalemia, so these are some of the conventional management of the hyperkalemia, but potassium binders can be used along with those medications that is needed to be given in a heart failure patient, so that the hyperkalemia, the significant hyperkalemia can be prevented. One important factor that we usually miss in the ABG analysis is that the level of the chloride. So if the hypokalemia present in the ABG analysis, it is less than 96, it is a powerful independent predictor of mortality in acute heart failure patient. So acetylzolamide actually increases the chloride level, and that actually helps to improve the heart failure outcome. So coming back to my patient, so this is a 60 years old lady, diabetic hypertensive patient. So definitely this patient needs immediate stabilizations of heart failure using NIV or the vasodilators and intravenous loop diuretics, and the management of the rhythm, like the atrial fibrillation. This patient may require the external cardioversion so that we can stabilize the patient, the rhythm, and the heart failure symptoms immediately. And the rest of the management protocol we can patient being stabilized. Thank you for your attention.